Mm, yeah, now we have come to this diabetes mellitus. It's a diet menace disease. So many of you would have known a lot of details regarding this diabetes mellitus. So in this session, we will try to know some of the basic features of this particular disease. Which would be really exciting. Okay. So this is Kishore from the So I'll be moving into the learning objectives of this session. It's type 1, type 2. What is type 1? What's the diagnosis for type 1? Then metabolic changes. Obviously, diabetes is to relate to that hyperglycemia. What is hyperglycemia? And why do we have this ketoacidosis? And how about this hypertriacylglycerolemia? And what is the treatment? And how to check these hypoglycemic episodes in diabetes. So those are the key themes which we will be looking in relevance to both type 1 and type 2. Here, as I said, diet menace disease. So type 2 is mainly related to that insulin resistance, obesity. Obesity is obvious disease if you don't take enough care. It's obvious. So then even I am beating on my overweight, having known some of these details. It's a harsh hormone related stuff. Okay. So then we will be knowing about those metabolic changes and then hyperglycemia, dyslipidemia, and then treatment, and then chronic effects, how this diabetes will really uh, eat into each tissue of the body. So that is that. And as being said by age-old sayings that prevention is better than cure. So this particular table, it gives you some of these details regarding uh, age of onset, prevalence, genetic predisposition, what is the defect, and then frequency of ketosis, plasma insulin, complications, and then hypoglycemic drugs. What are the treatment aspects? This is a very good cumulative sheet which we will be trying to explore. So generally, type 1 diabetes, it is like it usually occurs during childhood or puberty, and the symptoms they develop rapidly. And with relevance to this type 2, it is after age 35. So symptoms they develop gradually. So nutrition status at the time of the disease onset will be like uh, subjects will be undernourished, whereas here in type 2 they will be overnourished, they will be obese. So 10% diagnosed diabetics are they come under this type 1. 90% they are into this type 2. Then genetic predisposition is moderate, and here if we are blessed with that sweet gene, then it's a very strong correlation predisposition. Then how about this defect? What is defect in this type 1? So beta cells are destroyed, and production of insulin is almost done. Then insulin resistance is important in type 2 diabetes. So, so beta cells will be enable, like they will be enability of beta cells to produce appropriate quantities of insulin. If at all insulin is being produced, then the insulin receptor is defective in some cases. Then frequency of ketosis is common in type 1 diabetes, but it is rare because a lot of load of uh, or nourishment is there. Then plasma insulin is low to absent, but here early stage of the disease it is high and it is low after time because body tries to adjust that change in the metabolism by increasing insulin level. Now, what are the acute complications? Obviously, this will be ketoacidosis in type 1. In type 2, it would be hyperosmolar state. Okay. Hyperosmolar coma. Osmolar coma. Then response to oral hypoglycemic drugs, no way, you have to give insulin to them. And type 2, they will be responding to oral hypoglycemic drugs. The treatment insulin is always necessary. Small short. No, I think a lot of modifications have come in the treatment, but here type 2. So all these things have to be kept in mind: diet, exercise, oral hypoglycemic drugs, reduction of risk factors. Smoking is to be stopped, cessation of smoking, blood pressure control, treatment of dyslipidemia are essential for functioning of those drugs which we take for type 2 diabetes management. This would have given an outset like what is type 1, type 2. So now we will go into the details. So generally, so you can see this is regarding the years of autoimmune destruction of beta cells taken on x-axis, and this y-axis insulin secretory capacity. So here you can see what is the initiating event here. There might be some beta cell destruction due to virus or some genetic predisposition. So slowly beta cells destruction it starts, and it resulting in decreased production of insulin. This is happening here. So subclinical beta cell dysfunction will be seen in one phase, whereas this is that immunological trigger, and then gradual decline, slow beta cell destruction, and then subclinical beta cell dysfunction, and then particularly beta cells are completely destroyed. So when the insulin secretory capacity fails below this clinical threshold, then you can see that obvious symptoms of type 1 diabetes. So this graph is to relate to mainly type 1 diabetes mellitus, how it comes into picture, like starting with trigger, then subclinical, this is slow destruction, subclinical phase, and then you will have clinical disease by the time it gets reduced to the clinical threshold level. So now this one is to give you the idea why there is hyperglycemia in this diabetes mellitus. So we can see from intestine glucose is taken, and from liver en route this glucose 6-phosphate glucose is made, and it is being given out. So hyperglycemia results from increased hepatic gluconeogenesis and decreased glucose uptake by the insulin sensitive GLUT4 either in the adipose tissue or in the muscle. So obviously when insulin is not being produced, so glucagon is being produced, so you can see a cascade of reactions. So triacylglycerol is being made into fatty acid, and this goes to that, and then you will have formation of ketone bodies. So VLDL will accumulate, chylomicrons will accumulate. So amino acids from muscle and other peripheral tissues, they will be en route gluconeogenetic pathway, they will be moved to pyruvate, and then you will be seeing that blood glucose level is made high. Glucose is not utilized, and cell will be ridiculed by increasing the formation of glucose. So that is why you will have hyperglycemia in diabetes mellitus. So next, now we are trying to look into this very important parameter. This is that hemoglobin A1C. Uh, this hemoglobin A1C gives you the detail of this glucose concentration, which sustains for around suppose 120 days RBC lifespan. So you can know how the treatment is being progressing, how the glucose levels are maintained by that particular diabetic patient by monitoring the hemoglobin A1C value. So this is that mean blood glucose in milligrams per deciliter taken in x-axis, and this is that percentage hemoglobin A1C value. So we are trying to correlate it. So initially normal mean glucose in non-diabetic individuals, it should be around somewhere around 100. So wherein the value will be hemoglobin A1C value will be around 6%. So suppose some persons so concentrations are observed like typical mean blood glucose concentrations are observed in insulin dependent diabetes patients who are treated with intensive insulin therapy. So if someone is on intensive insulin therapy, so that HbA1c will be between 6 and 8. The mean level between 150. So standard insulin therapy, you see that this is somewhere around 225, and this mean like it is going towards 9. So what are the positive points? So insulin intensive like therapy results in threefold increase in the frequency of hypoglycemia. And then many clinicians believe that the risk of hypoglycemia that accompanies intensive therapy is justified by the substantial decrease in the incidence of long-term complications such as diabetic nephropathy and retinopathy. So you can see by intensive therapy, uh, this hypoglycemic episodes will be more than conventional therapy. So insulin resistance in peripheral tissues, which will be leading to increased production of glucose. So this glucose is made, and then it cannot enter into muscle or adipose tissue due to GLUT4 problem, that GLUT4 transporter. And then there is inadequate insulin secretion from beta cells. You won't be having insulin. So here, so insulin level in blood, and this is that glucose level in blood. So we are trying to compare, like, so from morning 8, and then this is regarding the time scale noon to midnight. So high insulin levels are required to control blood glucose in insulin resistant obese individuals. So basal insulin levels after each meal. So red graph indicates obese, and this one is normal. So insulin per micro units per ml. So here you can see less insulin is required for maintaining the blood glucose, or insulin levels are raised very high in obese individuals. Here this is regarding the blood glucose. So you can see, so blood glucose is kept within the same narrow range without throughout the day with both normal weight and obese individuals. You can see. So by this increased spikes, you can see body is trying to maintain this blood glucose level within the range. So when this insulin is not being there, then obviously there will be derailment of the process. So blood glucose and insulin in type 2 diabetes. Excuse me. So this is another important graph. So now we are trying to compare this glucose in milligrams per deciliter on y-axis, and this is that years of onset of diabetes. Let us say, okay, so years of diabetes, and this one is insulin secretion percent of normal. So if you look at this blue line, so you can see obese individuals will develop insulin resistance preceding actual diabetes, diagnosis of diabetes. You can see this is that. So maybe since 10 years they will be having that change in the fasting glucose values gradually. The patient diagnosed with type 2 diabetes initially they will show increased insulin, hyperinsulinemia, and subsequently when the beta cell dysfunction occurs, then there is marked hyperglycemia, and here you can see insulin is declined below the normal threshold. So from the diagnosis of diabetes, before that there will be increase in insulin, and then gradually insulin levels of untreated diabetes type 2 it will be declining, and this hyperglycemia gradually it will shoot up. So this is comparison between fasting glucose as well as insulin levels in untreated type 2 diabetes mellitus. Very important. And then what does this insulin resistance do? So you have many predisposition factors like genetics, obesity, sedentary lifestyle, aging will stimulate this insulin resistance. So here insulin resistance will lead to hyperinsulinemia and then impaired glucose tolerance, then decline in beta cell function, and then leading to type 2 diabetes mellitus. So genetics and glucose toxicity and free fatty acid toxicity also will lead to decline in beta cell function. Then there are two important terms: microvascular complications and macrovascular complications. So retinopathy, nephropathy, and neuropathy are microvascular complications, whereas cardiovascular disease or stroke they are being considered as macrovascular complications. So now we will look into the intertissue relationship in type 2 diabetes. So we have been looking into this part: liver, adipose tissue, and muscle, and pancreas, all this stuff. So here uh, same thing is happening, like increased hepatic glycogenolysis and gluconeogenesis, and these fatty acids again they are rooted into ketone body formation. Chylomicrons they accumulate, VLDL they accumulate. The diminished effects of insulin on target tissues results in insulin resistance. So you can see even amino acids will be channeled to gluconeogenetic precursors to go to pyruvate and then gluconeogenesis. Then this is important term, that is glycemic control. What is glycemic control? So all those food commodities which will shoot up the glucose level per gram of consumption, so they have been categorized into high glycemic compounds. So that if it is advisable to consume those to reduce the consumption of those glycemic index related compounds, so particularly potato chips and all that oil related molecules, food stuff. So benefits of improvement of glycemic control. So it occurred around improvement in glycemic control is always beneficial. Suppose so length of follow up you can see. So all those people who are like within the range of this say 6 to 7 and 8, they have less prevalence of retinopathy. So mean HbA1c, if it is around 11, then they have almost high prevalence of retinopathy. So if the mean HbA1c value is being kept below 8% or near to 7, then then there is less chance of having a retinopathy. So this blue, brick red, and then green blocks being shown in this particular graphical representation. So what is body mass index? So weight in kgs by height in meter square is body mass index. So we are comparing this body mass index with the incidence of type 2 diabetes. So here you can see per every 10,000 patients per year, they have compared this with this body mass index. You can see obesity and sedentary life promote to the development of type 2 diabetes mellitus. So always note, little exercise is always hazardous. So now we have come to that is that summary sheet. Yeah. So type 1 diabetes mainly it will be due to immunological trigger, which will lead to dysfunction of beta cells and leading to loss of insulin secretory capacity. So type 1 diabetes, you will see all these three: polyuria, polydipsia, and polyphagia. So they share the common features. Three P's: polyuria, polydipsia, and polyphagia. Polyuria is excessive urination, polydipsia excessive thirst, and polyphagia is excessive hunger. And here obesity leads to insulin resistance and it is characterized by hyperinsulinemia, and then gradually there will be decline in the beta cell function, and that will be leading to type 2 diabetes, and then this is sometimes it may be asymptomatic or they will be exhibiting this polyuria, polydipsia, and polyphagia. So both absolute or relative deficiency of insulin, it is characterized by abnormal metabolism. So this is that abnormal metabolism. So here there are some long-term complications. So here if you look into the details, increased breakdown of tissue proteins leads to increased gluconeogenesis. Hepatic output of glucose is increased, glycogenolysis, and this would lead to hyperglycemia. And there is another rationale that glucose uptake by tissues is insulin sensitive. So when insulin is not there, then again it will lead to hyperglycemia because glucose will not be taken into the tissues. And here regarding this, ketosis may be absent or present, or it may be there in the it may be moderate in type 2 diabetes. So increased lipolysis, free fatty acids are increased, hepatic output of ketone bodies is increased, which would lead to ketoacidosis. So long-term complications: macrovascular and macro and microvascular, so which we have seen: retinopathy, neuropathy, and nephropathy. Thank you.